Hi, everyone. Welcome to our Montefiore Grand Rounds. It's a great pleasure to introduce today Dr. Sanjay Kaul, who will be talking about the evolution of SGLT2 inhibitors from management of glycemic control to mitigating cardiorenal metabolic risk. Dr. Sanjay Kaul is a cardiologist at Cedars-Sinai Medical Center in LA. He was the program director of the cardiology fellowship initially when I went there. He has a long history of relationships and approvals and evaluation of medications for the FDA. He has, I think, is one of the highest value critical thinkings into analyzing data. Every time I heard one of his conferences, I learned so much, and things I thought I understood, then I realized they were deeper and more complex. So it's a great pleasure to introduce you today, and we're waiting for your talk and looking forward to learn from you.
Thank you, Leandro. I'm delighted to be invited to present the cardiology grand rounds at Montefiore. Let me see, not able to. These are my duality of interests, and I'll be talking on four main areas today. I'll start off with reviewing briefly the pharmacology and the metabolic effects of these SGLT2 inhibitors, and then spend more time on regulatory and evidentiary landscape. First, talk about the cardiovascular outcome trials in patients with established Ascbd or multiple risk factors for Ascbd, then talk about heart failure in patients with reduced ejection fraction with or without type 2 diabetes, and then the chronic kidney disease trials in patients with or without type 2 diabetes. Briefly touch upon mechanistic insights. The long and the short of it is we still don't know exactly how these drugs are cardio protective. And lastly, briefly review with you the guideline recommendations for mitigating cardiorenal metabolic risk. So let's start off with some pharmacology of these receptors. The SGLT2 is primarily expressed in the kidney, where it reabsorbs 90% of filtered glucose. And we know from genetic studies that mutations in the gene that encodes for the SGLT2 receptor leads to a benign condition called familial renal glucosuria. And there have been several pharmacologic inhibitors that have been developed to inhibit the SGLT2 receptor. The SGLT1 is primarily expressed in the small kidney, small intestine, but it's also expressed in the kidney and heart. In the intestine, it is the primary transporter for absorption of glucose and galactose in the GI tract. And mutations in the gene that encodes for this receptor leads to a life-threatening diarrhea, a condition called glucose-galactose malabsorption. And the one that is in the development program is sotagliflozin, which is actually a dual T1 and T2 receptor inhibitor. So the SGLT2 inhibitors, by blocking the reabsorption of glucose and sodium, eventually lead to significant urinary glucose excretion, natriuresis, and osmotic diuresis. And these lead to downstream effects, culminating in a drop in blood pressure, drop in weight, improvement in cardiac function by impacting the preload and the afterload. And there is some evidence to suggest that these drugs also have an impact on the cardiometabolic efficiency, utilization of fatty acids versus glucose. There is some evidence to suggest that these reductions in preload and afterload also result in regression of left ventricular hypertrophy that we see in patients with type 2 diabetes. And obviously there is, with the glycosuria, that's how it improves the glycemic control. And there's also strong evidence that they improve kidney function. So as of this morning, there are 4 SGLT2 inhibitors that have been approved in the United States. All 4 of them have been approved for glycemic control in patients with type 2 diabetes, starting with canagliflozin in 2013. And ertagliflozin was the last one to be approved for glycemic control in 2017. With regards to MACE or cardiovascular death in patients with type 2 diabetes and atherosclerotic cardiovascular disease, there are 2 drugs that are approved. One is canagliflozin and empagliflozin. With regards to reducing the risk of hospitalization for heart failure in patients with type 2 diabetes and Ascbd or multiple cardiovascular risk factors, dapagliflozin is the only one approved for that indication. For reducing cardiovascular death and hospitalization for heart failure in patients with HFrEF with or without type 2 diabetes, again, dapagliflozin is the only one that's approved. The European agency just recently announced about 10 days ago that Jardiance or empagliflozin is also indicated in this scenario. The US FDA has not weighed in yet. And for nephroprotection in patients with or without type 2 diabetes, canagliflozin and dapagliflozin are approved for those indications. So let's briefly review some of the metabolic effects of these SGLT inhibitors. There are some subtle differences. For example, empagliflozin has the greatest selectivity for the SGLT2 receptors, followed by ertagliflozin and dapagliflozin, and Cana has the least selectivity for SGLT2 inhibitors. It is not clear what the clinical relevance of the selectivity is. In terms of glycemic efficacy, they are modestly effective, roughly about 0.7 to 1.2% improvement in hemoglobin A1C. Modest weight change, somewhere between 2.5 to 3.7 kilograms. Modest effect on blood pressure, somewhere between 4 and 5 millimeters in the systolic blood pressure. All of them reduce volume. Canagliflozin probably has a greater effect on volume depletion than other agents, probably because there is much more glycosuria with canagliflozin. There's a peculiar phenomenon with all these SGLT2 inhibitors that they actually increase LDL levels, somewhere between 5 to 8 milligram per deciliter increase in LDL. And there are some studies showing that the type of LDL that's increased is the large buoyant type of LDL, which is probably not as pathogenic. And none of these agents by themselves cause significant hypoglycemia, but when used concomitantly with sulfonylureas and insulin, you have to be careful about the potential for hypoglycemia. So this is the evidentiary landscape for the cardiovascular outcome trials that have been launched since the FDA guidance in 2008. Over 26 trials have been launched, 23 of them completed in nearly 210,000 patients. With SGLT2 inhibitors, there were actually 10 trials completed. Now remember, the FDA guidance in 2008 required ruling out unacceptable cardiovascular risk with these agents. Reassuringly, not a single agent was associated with increased cardiovascular risk. Not only did they rule out unacceptable cardiovascular risk, in some scenarios, actually there was demonstration of cardioprotection as well as nephroprotection in these trials. So these agents have been evaluated along a spectrum of cardiovascular risk, mostly in patients with established cardiovascular disease or at high cardiovascular risk. And we have these 4 trials. They are based on the preliminary observations derived from these trials on heart failure outcomes as well as renal outcomes. Dedicated trials were launched in these specific scenarios to evaluate the role of these agents. For example, in the heart failure field, we have DAPA heart failure, emperor-reduced, and soloist worsening heart failure trial that was completed. A couple of these trials are still ongoing in the HFpEF, heart failure preserved ejection fraction scenario. And then there are studies that were also done with chronic kidney disease, such as Credence, DAPA-CKD, and SCORED. There are ongoing studies evaluating the role of these agents during the setting of myocardial infarction. We have the IMPACT-MI with empagliflozin, DAPA-MI with dapagliflozin, and then during acute heart failure admission, IMPULSE with empagliflozin, and DAPA-ACT heart failure, TIMI-68 with dapagliflozin. So most of the evidence so far that we have seen is derived from high-risk category patients. So let's briefly review these 4 trials, the CBOT trials in ASCVD or multiple risk factors. There are 4: EMPA-REG Outcome, Canvas Program, Declare TIMI-58, and VERTIS-CV. The median follow-up ranged from around 2.5 to 4 years. Baseline hemoglobin A1C was around 8.1 to 8.3. Most of them had diabetes duration greater than 10 years. EMPA-REG Outcome and VERTIS-CV, virtually all of them had established cardiovascular disease. Canvas, about 2/3 had cardiovascular disease. And then Declared TIMI-58, about 41% had cardiovascular disease. Now, these studies were not designed to evaluate the impact on heart failure. So the investigator reported prevalence of history of hospitalization for heart failure was around 10% in EMPA-REG Outcome to around 24% in VERTIS-CV. And as you can see, very few of them had more than moderate kidney impairment. So EMPA-REG Outcome is very similar to the VERTIS-CV trial. Both of them enrolled higher risk patients. So what I'm going to do is share with you how the FDA evaluates the strength of evidence to support effectiveness of drugs and biologics. This does not apply to the approval of devices. So the statutory criteria for approval at the FDA is the so-called substantial evidence of effectiveness consisting of adequate and well-controlled investigations. The plural there implies the requirement of 2 separate trials, each with a p-value of less than 0.05. So when you do the math, one-sided p-value of 0.025 times another 0.025 roughly translates into a p-value of 0.001. So this was the original FDC Act from 1962. In 1997, they modified it to requirement of only 1 adequate and 1 controlled study plus some confirmatory evidence. And the FDA came out with the evidence guidance first in the 1998, and the latest iteration was in 2019. Which says that highly reliable and statistically persuasive. When we say statistically persuasive, the p-value has to be very robust, less than 0.001. Evidence of an important clinical benefit in a single trial with some indication of study's reliability. That would be sufficient to garner a regulatory claim. So the interpretation of trial results should be based both on quality as well as quantity. So we are going to apply this metric to the evaluation of these trials. So let's go with the quality attributes. These are all double-blind, placebo-controlled, adequately powered studies. What is remarkable about these trials is that there was very little amount of missing data with respect to primary endpoints. And with respect to the vital status, less than 1% of the data was missing, and none of these trials were prematurely stopped. Why is that a key quality attribute? Trials that are prematurely truncated tend to overestimate benefit and perhaps in some scenarios underestimate risks. So clearly, all of these trials had high quality attributes. With respect to the quantity of evidence, again, I want you to focus on the p-value and the substantial evidence column, and then what the FDA's approved indication was. With regards to the EMPA-REG outcome, even though the primary endpoint was the 3-point MACE, the effect size was rather modest and the p-value was not very robust. But this 3-point MACE was driven by a 38% reduction in cardiovascular death, a large effect size. The p-value was very robust, met the substantial evidence criteria, and not surprisingly, the FDA's approval was limited to cardiovascular death, not 3-point MACE and EMPA-REG outcome. Similarly, with CANVAS, the primary endpoint, there was a modest reduction. The p-value was not robust. This was based on the all cohorts. Remember, 66% had CVD and the remaining 1/3 had multiple risk factors. But when you focus your analysis only on those with established cardiovascular disease, the effect size is larger, the p-value is more robust, it does meet the substantial evidence criteria, and FDA approved canagliflozin for patients with established cardiovascular disease only, not for those with multiple risk factors. Similarly, when you look at declared TIMI 58, there were two co-primary endpoints. One was the conventional 3-point MACE, and then the other one was the heart failure endpoint, the cardiovascular death or hospitalization for heart failure. So the 3-point MACE non-inferiority was met, but superiority was not met. The second co-primary endpoint, the large effect, a modest effect size, p-value close, but it was driven by reduction in hospitalization for heart failure, not reduction in cardiovascular death. Substantial evidence criteria was met. The FDA limited its indication only for hospitalization for heart failure. With VERDIS-CV, primary endpoint of non-inferiority was met, but superiority was not met. And the only endpoint that was significantly reduced in VERDIS-CV was the hospitalization for heart failure, which was an exploratory endpoint, meaning in the statistical hierarchy of testing, there were endpoints preceding this that were not significantly reduced, such as the cardiovascular death, hospitalization for heart failure. So this is how the FDA approves indication based on this substantial evidence criteria. So what I would like to share with you is evaluation of benefit risk. The only calculus that the FDA uses in approving drugs or biologics or devices is whether the benefit exceeds the risk. So this is one way of expressing the benefit risk balance. So for every 1,000 patients treated with empagliflozin for 3 years, what was the benefit accrued? 20 MACE events were reduced, and 28 deaths were reduced, and 16 hospitalizations for heart failure were reduced. The hospitalization for heart failure is an exploratory analysis due to testing hierarchy. When we talk about exploratory analysis, it means it is not actionable for regulatory decision making. And now the journals have also adopted this format, and they require that the p-values not be reported for these exploratory endpoints. What is the safety trade-off? There are 57 excess genital infections, but more importantly, there's no excess complicated UTIs, bone fractures, DKA, venous thromboembolic events, and there were favorable effects on acute kidney injury and treatment discontinuation. So clearly, based on this benefit-risk balance, we can conclude that the benefit exceeds risk, justifying strong guideline recommendation. So same thing for the CANVAS, 1,000 patients treated with canagliflozin for 3 years. You have 14 MACE events prevented and 10 hospitalizations for heart failure and 10 renal events. But there were 72 excess genital infections. For the first time, we observed that there were 9 excess lower limb amputations, 11 excess bone fractures, and 7 excess volume depletions. Here, the benefit exceeds risk in patients only with established atherosclerotic cardiovascular disease, and that's what the indication was limited to. This is the DECLARE TIMI 58 benefit risk balance. Again, you can see that there were reductions in heart failure hospitalizations at the cost of some excess genital infections, 2 excess DKA, and 9 discontinuations due to adverse events. The benefit exceeds risk, justifying strong guideline recommendations. And this is the benefit risk balance for the VERTIS CV. You have 1 MACE event reduced, 10 hospitalizations for heart failure, but this is an exploratory endpoint at the cost of 39 excess genital infections, 20 excess UTIs, and even 3 excess DKA events. There were non-significant increase in amputation with ertugliflozin. So the question I pose to you is, does the benefit exceed the risk? The FDA has not weighed in terms of the cardio protection indication for VERTIS, for ertugliflozin yet. So there have been several meta-analyses that have been conducted to explore the effects on different outcomes. What we can say from these meta-analyses is that there's a modest but inconsistent effect on the 3-point MACE. The I-square is about 23%. This is the heterogeneity index. There's a large and consistent effect on hospitalization for heart failure. The I-squared here is 0. There is no effect on atherothrombotic events of MI or stroke. In the empagliflozin, there was a concerning increase in risk for stroke, which reassuringly was not replicated in this other trial. So this probably represents a spurious observation. There is no effect on the MI or stroke. There's a large but inconsistent effect on renal outcomes, and empagliflozin happens to be the only SGLT2 inhibitor that has a large cardiovascular death benefit, but the I-square here is quite large. So the people often ask me the question about whether it is a class or a drug-specific effect. Let me share with you from a regulatory perspective that it is irrelevant whether it's a class or drug effect. Each drug within the class requires a registration trial for approval. Yes, there are some differences amongst the selectivity for the SGLT2 receptors, but in terms of metabolic effects, it's common to all 4 agents, but there are different effects on efficacy as well as safety outcomes. So with regards to Ascbd in type 2 diabetes patients, empagliflozin is the only SGLT2 inhibitor with proven cardiovascular and all-cause mortality benefit. DAPA is the only SGLT2 inhibitor with proven benefit in reducing hospitalizations for heart failure. CANA is the only SGLT2 inhibitor with proven MACE risk reduction and increased amputation and fracture risk. Prior to 2020, the canagliflozin carried a boxed warning for amputation, which has been subsequently removed, but it's still a warning in the warnings and precautions section. Ertugliflozin has no unique attribute and has the least favorable benefit risk profile compared with other agents in the class. Excuse me. Excuse me. So let's talk about the heart failure trials. The heart failure outcomes that we saw in the Ascbd trials was more of a prevention effect. But they're based on those observations, dedicated trials were launched. We have 2 trials that have been completed, DAPA heart failure and EMPEROR reduced. There are 2 trials still ongoing in the HFpEF program, also in the acute heart failure hospitalization program, as well as in the more proximal scenario in the acute coronary syndrome scenario. So we'll focus on the DAPA heart failure and the EMPEROR reduced. What I've done here on the slide is compare and contrast these 2 trials. The mean ejection fraction was slightly lower in EMPEROR-reduced, 27% versus 31%. The baseline NT-proBNP biomarker levels were higher in the EMPEROR-reduced. About 31% were hospitalized within 1 year prior to randomization. And there was a higher background use of ARNI, about 19% in EMPEROR-reduced compared to about 11% in DAPA heart failure, higher use of ICD-CRT in EMPEROR-reduced. So there is a higher risk cohort enrolled in EMPEROR-reduced compared with DAPA based on a deliberate enrichment strategy. So let's look at the overall results. Now, in DAPA heart failure, the primary endpoint was cardiovascular death or worsening heart failure, which included urgent heart failure visits. The EMPEROR-reduced used the conventional heart failure endpoint, which is cardiovascular death and hospitalizations for heart failure, did not include urgent heart failure visits. So what you see here is, I want you to focus on the placebo event rates. Here, the incident rate is 21 compared to 15. So yes, the enrichment strategy in EMPEROR-reduced worked, leading to a higher incidence of the primary endpoint. But this was not due to increase in the cardiovascular death incidence, but driven by increase in the risk of hospitalization for heart failure. So enrichment strategy in EMPEROR-reduced amplified hospitalization for heart failure, but not cardiovascular death. Cardiovascular death was significantly reduced in DAPA heart failure, but not in EMPEROR-reduced. When you look at all-cause mortality, mortality benefit was observed in DAPA heart failure, but not EMPEROR-reduced. And the renal outcome benefit was observed in EMPEROR-reduced, but not DAPA heart failure. And health-related benefits were observed in both based on the Kansas City cardiomyopathy questionnaire. So when you look at the benefit-risk balance, and here I have extrapolated to 1 year, standardized it to 1 year, even though the follow-up is slightly longer. So for every 1,000 patients treated with dapagliflozin, here are the benefits listed: no excess volume depletion, amputation, fracture, DKA, hypoglycemia, or Fournier's gangrene in the DAPA heart failure. So clearly benefit exceeds risk in HFrEF, justifying FDA approval and guideline recommendation. And based on this, the FDA approved DAPA heart failure in May 2020 to reduce the risk of cardiovascular death and hospitalization for heart failure in adults with heart failure with reduced ejection fraction, mostly class 2 and class 3 heart failure, but the label extends to class 4 heart failure. This is the benefit risk balance for EMPEROR-reduced. You have similar type of favorable profile, except that the all-cause deaths and cardiovascular deaths are not significantly reduced. So benefit exceeds risk in HFrEF. The European regulatory agency has given a favorable decision that needs to be confirmed shortly. The supplemental drug application for empagliflozin is still under review at the FDA, and we expect the FDA to come up with its decision in the next couple of months. So the mortality benefit that was observed in the EMPEROR outcome was not replicated in the EMPEROR-reduced, despite a higher number of mortality events observed in EMPEROR-reduced, roughly about 389 versus 309 in EMPEROR. And so what we've seen here is there's clearly a heterogeneity of cardiovascular death outcome benefit in the two trials. A 38% risk reduction here versus only at 8% risk reduction. The sponsors of EMPEROR outcome study and EMPEROR-reduced study actually did a pooled analysis of both EMPEROR-reduced and DAPA heart failure, and then came up with a pooled effect size of 14% risk reduction with respect to cardiovascular death 13% risk reduction in terms of all-cause death. And they concluded that there is no heterogeneity of mortality of benefits across these two trials. Well, I don't know about you. I have issues with these types of analyses. I mean, if we use the same criteria where we could pool the results of EMPA-REG outcome with DECLARE and show and demonstrate that dapagliflozin also has a mortality benefit which is not any different from EMPA-REG outcome. Again, as I said, I have issues with these types of analyses, and these are meta-analyses based on pooled, on studies effect sizes. They are not based on individual patient-level data meta-analysis, which can be informative. So far, the heart failure outcome trials were done in the setting of stabilized heart failure, what we call ambulatory heart failure. As we showed again that in DAPA heart failure, 27% had history of hospitalization within 1 year of randomization and 31% in EMPEROR reduced. Have been some pilot studies done during the acute phase of decompensated heart failure. There was one study called EMPA Response Acute Heart Failure that was published European Journal of Heart Failure, and there were about 80 patients. The primary endpoint, which was a composite endpoint, was not met, but there was increased urinary output confirming a diuretic effect of this drug. There is a study done with sotagliflozin called Soloist Worsening Heart Failure, where patients were randomized prior to discharge from the hospital. Roughly about half the patients were randomized, but they were randomized in the late acute phase, not in the early acute phase. And there are currently ongoing studies addressing that. So unfortunately, the sponsors of sotagliflozin ran out of funds, and because of COVID-19, they had to prematurely stop the enrollment. Soloist worsening heart failure, the original sample size was 4,000, but they stopped the trial when they had enrolled about roughly 1,200 patients. And about 50% of them, about a quarter of them had ejection fraction over 50%. The follow-up was truncated to about 9 months. Scored, they enrolled larger number of patients, but the follow-up was limited to only 14.2 months. And the endpoints were not adjudicated because of the lack of funds in both these trials. The revised primary endpoint in soloist heart failure was the cardiovascular death or hospitalization for heart failure, as well as urgent heart failure visits, including recurrent events. So this was the total number of event analysis, a 33% risk reduction that met the substantial evidence criteria. But cardiovascular death and death due to any cause was not reduced. It was all driven by the total number of events for hospitalization for heart failure and urgent heart failure visits. Scored, the original primary endpoint was the 3-point MACE, and the revised primary endpoint, this was revised before the data was unlocked, was cardiovascular death or hospitalization for heart failure, including urgent heart failure visits. So a 26% risk reduction in the revised primary endpoint meets the substantial p-value criteria. Had they not changed or revised the endpoint, it would have still met the original endpoint, 16% risk reduction, but would not have met the substantial p-value criteria, the persuasive p-value criteria. So this is the benefit risk balance for 1,000 patients treated with sotagliflozin for 1 year. Remember, this is a higher risk patient population, so you will have larger numbers reflected here. 253 fewer primary endpoint events, mostly driven by hospitalization for heart failure. Yes, there was excess diarrhea, as you would anticipate with inhibiting absorption of galactose. There were also 15 severe excess hypoglycemia, but benefit exceeds risk in worsening heart failure, but mortality is not reduced. scored a lower risk population. The numbers are lower here. Again, you get diarrhea, volume depletion, so you get some excess DKA, but you don't see amputation, fracture, or foreignness ganglia. So benefit exceeds risk in diabetic CKD, but mortality is not reduced. So Dr. Deepak Bhatt they pooled the results of SOLOIST and SCORED and presented these data in the virtual ACC meeting a month ago. When you look at the all-comer data, they stratified it according to ejection fraction levels, less than 40%, 40 to 50, and greater than 50%. And you will see that the benefits with respect to cardiovascular death or hospitalization for heart failure exceed up to an ejection fraction of about 60-65%. The absolute risk benefit in the ejection fraction greater than 50% criteria in strata is lower, about 1.7. But when you restrict the analysis to those with history of heart failure, about 4,500 patients, the absolute risk benefit here is much higher, despite the relative risk being very similar. So these are the first randomized trial data to show a potential benefit in heart failure with preserved ejection fraction, and probably augurs well for the EMPEROR preserved and the DELIVER studies with dapagliflozin. Now we'll switch over to the chronic kidney disease. We have two trials, CREDENCE and DAPA-CKD. About 50% in CREDENCE had established cardiovascular disease history, roughly about 37 in DAPA-CKD. CREDENCE, all patients had type 2 diabetes. DAPA-CKD, about 2/3 of them. Heart failure hospitalization history was 15% in CREDENCE, 11% in DAPA-CKD. Both of them had significant albuminuria, and the EGF levels were lower, mean EGFR levels were lower in DAPA-CKD. The primary endpoint in CREDENCE was the end-stage renal disease, the doubling of serum creatinine or equivalent of EGFR decline greater than 57%, cardiovascular or renal death. The DAPA-CKD included EGFR decline greater than 50%. So it's a softer, relatively softer endpoint in DAPA-CKD. With respects to quality, they are consistently high quality design, except both the studies were stopped prematurely. CREDENCE was stopped at the first interim analysis when only 405 out of 844 planned events accrued. And DAPA-CKD was stopped due to an unplanned interim analysis when 408 out of 681 events had accrued. So those are the only two the trials in this space that were prematurely truncated. With respect to the quantity of evidence analysis, in CREDENCE, you see the primary endpoint as well as the cardiovascular death, hospitalization for heart failure, as well as hospitalization for heart failure met the p-value criteria for substantial evidence. And the FDA approved indication is also restricted to these endpoints. With respect to DAPA-CKD, again, the primary endpoint, as well as the cardiovascular death, hospitalization for heart failure criteria met the substantial evidence criteria, and the FDA approval is also limited to these endpoints. There was a reduction in all-cause mortality in DAPA-CKD without a reduction in cardiovascular death, implying that there was a significant reduction in non-cardiovascular death. These are what I call incoherent data, and I'm not aware of any SGLT2 inhibitor that would reduce a non-cardiovascular death. So this is probably a spurious or a false positive finding in DAPA-CKD. So here's the benefit risk balance for CREDENCE. Again, clearly exceeds risk, benefit exceeds risk, justifying FDA approval and guideline recommendation. This is, and the FDA in September 2019 approved canagliflozin to reduce the risk of end-stage kidney disease, doubling of serum creatinine, cardiovascular death, and hospitalizations of heart failure in adults with type 2 diabetes mellitus and diabetic nephropathy with albuminuria. So that was the indication from Credence. This is the benefit risk balance from DAPA CKD. Again, the benefit the risk balance looks very favorable. And about a month ago, the FDA approved dapagliflozin to reduce the risk of sustained eGFR decline, end-stage kidney disease, cardiovascular death, and hospitalization for heart failure in adults with chronic kidney disease at risk of progression. So now I'm going to talk a little bit about the mechanism of action. I mean, we simply really don't understand the exact mechanism of benefit, but there are some studies that are addressing these mechanisms. In my opinion, the most likely pathway that is involved is this improved renal function through tubuloglomeralar feedback, which leads to afferent arterial vasoconstriction and reduction in hyperfiltration, reduction in preload, afterload. And that's probably the most likely pathway. Changes in blood pressure, weight, lipids are less likely to mediate the benefit. And there are several papers written on these effects on sodium hydrogen exchange, maybe on the inflammasome, maybe they have some effect on erythropoietin, reduced sympathetic nervous system activity, improved myocardial energetics, but none of them are proven. They are worth exploring, but then none of them are proven at this point. I want to share with you briefly that some of the studies that were presented in the last few months, published in JACC, Circulation JAMA Cardiology, showing that empagliflozin treatment for 12 to 36 weeks improves cardiac function and adverse remodeling in heart failure with reduced ejection fraction patients with or without type 2 diabetes. Earlier, Dr. Verma had published in Circulation the results of EMPA Heart CardioLink 6, where EMPA exposure for 6 months was associated with a regression of left ventricular hypertrophy, as assessed by cardiac magnetic resonance imaging. So there's some evidence that there is improvement in adverse LV remodeling in heart failure. So lastly, in the last 7 minutes, I'm going to talk about guidelines. This is the 2019 ESC EASD guidelines. And why I like to show this is that for the first time, the guidelines basically said that if you are a high-risk patient and you are treatment naive, there is really no reason to start metformin. You can go ahead and start a SGLT2 inhibitor or a GLP-1 receptor agonist as the first line. So this is for the first time the guidelines deviated from the conventional practice of recommending metformin as the first line. But they say that if you're, you can always add metformin for glycemic control. And on the other hand, if you are already on metformin and you have these high risk factors, you can add SGLT2 inhibitor to it. And this is based on this sorts of analyses where there was no significant treatment by metformin interaction with respect to GLP-1 receptor agonists and SGLT2 inhibitors. This is shown on this, excuse me, these results where metformin versus no metformin risk ratios were compared. Again, there's no difference with GLP-1 receptor agonists and SGLT2 inhibitors. There appears to be some effect modification seen in the DPP-4 inhibitor trials. So what do the guidelines say? They have a class 1 level A recommendation for EMPA, CANA, and DAPA in patients with type 2 diabetes and CVD at very high severe risk to reduce cardiovascular events. EMPA has a mortality recommendation and a class 1 level B recommendation. What about the heart failure recommendations? Class 1 level A recommendations for all 3 SGLT2 inhibitors to reduce risk of hospitalization for heart failure. TZDs and DPP-4, especially saxagliptin, are contraindicated in patients with heart failure for hospitalization. The 2020 ACC expert consistent decision pathway emphasized that decisions on prescribing GLP-1 receptor agonist or SGLT2 inhibitors for cardiovascular or kidney disease reduction should not be contingent on a patient's A1C level. And they did not give any preference for any specific SGLT2 inhibitors. Any one of the three at that time were recommended. This is the 2021 ADA Standards of Medical Care. They say a first-line therapy should be metformin and comprehensive lifestyle. And then independent of hemoglobin A1C, if they have high-risk features, especially Ascbd established or high-risk features, you can start with either GLP-1 receptor agonist or SGLT2 inhibitor. The 2020 iteration of this guideline had emphasized GLP-1 receptor agonists specifically for those with established Ascbd and SGLT2 inhibitors for specifically for those with history of heart failure. That dichotomy has been eliminated in this updated recommendations. For DKD and albuminuria, SGLT2 inhibitors are preferred, and if they cannot be tolerated, then you can use GLP-1 receptor agonist. If they don't have diabetic kidney disease or albuminuria, then you can go with either GLP-1 receptor agonist or SGLT2 inhibitor. The 2021 update of the 2017 heart failure guidelines were released a couple of months ago. And they say that you start with ARNI as the preferred initial treatment after beta blocker and diuretics. And then you can use SGLT2 inhibitors, either DAPA or EMPA. You can go up to 30 milliliters eGFR with DAPA and up to 20 with empagliflozin. The Canadian guidelines are the most comprehensive guidelines, and they have given 4 different guideline recommendations. Each 4 of them have a strong recommendation supported by high quality of evidence. And I wanted to share with you that clearly these therapies are underutilized in clinical practice because of the cost, a little bit to do with clinical inertia as well. This cost-effective analysis was just published last week in JAMA Cardiology. And the incremental cost-effectiveness ratio for dapagliflozin in a heart failure cohort in the United States was roughly about $84,000, which means it's consistent with intermediate economic value according to ACC/AHA benchmarks. Now remember, 50 to 150,000 is intermediate value, less than 50,000 is high value, and low value is greater than 150,000. So this is driven by cardiovascular death. And in the non-US settings, it's likely to be cost effective. But I want to show you the comparison with UK. Despite a similar QALYs gained in the United States compared to UK, the cost effectiveness ratio here is about 12-fold higher. Why? Because the annual cost is roughly about 9-fold higher in US compared to UK. So roughly about $16 per day worth of cost to the patient. When during the COVID-19 pandemic, people were concerned about potential risk of diabetic ketoacidosis with these inhibitors. So a study was done by Mikhail Kosiborod called the DARE-19 study, about 1,250 patients, including 50% with type 2 diabetes. Bottom line, there was null outcome for primary composite outcome, organ failure, or death, but reassuringly, there was no increase in risk of AKA, acute kidney injury, or DKA. It's reassuring, but we don't know how many patients with type 2 diabetes were insulin, which is where the risk of DKA is maximum. So does that mean should we still discontinue SGLT2 inhibitors in acute illness? The data are promising and they need to be explored further. I want to share with you one last piece of information. The question often gets asked, yeah, we use metformin for prevention of new onset diabetes in patients with prediabetes. Can we use SGLT2 inhibitors to demonstrate for reducing the risk of new onset diabetes? And this was explored both in DAPA heart failure and EMPA-reduced. The positive effects seen in DAPA heart failure were unfortunately not replicated and emperor reduced. So these are exploratory analyses, and therefore at this point we should not use these agents for prevention of new onset diabetes in patients with prediabetes. So I'll conclude. I think we have 10 minutes for Q&A. SGLT2 inhibitors are much more than just an effective glucose-lowering therapy for type 2 diabetes. They reduce risk of developing heart failure. They reduce risk of hospitalization and death in patients with established heart failure with reduced ejection fraction, and they improve health-related benefits. They reduce the rate of decline in eGFR in patients with reduced ejection fraction and the risk of end-stage kidney disease in patients with chronic kidney disease. So just beyond improving glycemic control, they clearly protect the heart and kidneys and should become the standard of care in mitigating the cardiorenal metabolic risks. We have some knowledge gaps. Does concomitant therapy with GLP-1 receptor agonists mitigate cardiovascular renal risk? There's some preliminary data showing additive effects, metabolic effects. What about the mechanistic insights? One has to be cautious about risk of infection, the diabetes the diabetic ketoacidosis. Remember the sick day rule where you stop these inhibitors for a few days during acute illness. Remember about hypoglycemia with concomitant use with insulin and sulfonylurea. There's this questionable risk of amputation with cana and ertugliflozin. We need to be careful about avoiding volume depletion and dehydration, particularly in elderly and frail individuals. They should not be used in patients with type 1 diabetes. The US FDA did decline approval of these agents in type 1 diabetes, where the risk for DK is the highest. The challenge is how do we prioritize the role of these agents among an array of therapies? The cost is a major challenge. Polypharmacy is a major challenge, and clinical inertia is a major challenge. So I'm going to stop there. I'd be happy to take your questions. Thank you very much for your attention.
Thank you very much. That was an outstanding lecture. I think we have Dr. Garcia also now join us. That was an amazing lecture, and I think it's, like I was saying before, it seems simple if you say it's a class effect, but the data from the trials is not exactly the same for all of those. Please put your questions in the Q&A. I don't know if Dr. Garcia, you want to start with the first question?
Yes. First, Sanjay, thank you so much for such a comprehensive, well-done presentation. One of the challenges that I have when we have a speaker like you is to come up with questions that are reasonable. As I was thinking of a question to ask you, you were answering them all along. But I do have two that maybe you can spend a couple minutes in giving your opinion. Clearly, you show that the benefit is the same in patients who are on metformin or not. I wonder if you have enough data to comment on the patients who are type 2 but require insulin. Are the benefits similar to the ones that don't require insulin? The second question is,
could you repeat that? I lost
the same benefits in part. I am sorry. You demonstrated that in patients on metformin, the benefit is achieved regardless of the use of metformin or not. I was wondering if you know if the benefits are similar to patients who require insulin in addition, yes, in type 2. And the second is whether you see the same beneficial effects for cardiovascular event reduction in patients that have hemoglobin A1C on target at the time of initiation of therapy versus those who are not controlled.
Yes, very good question. Thank you, Mario. Thank you for inviting me. I was last there, I think, about 15 years ago, and I enjoyed that visit too. About 40 to 50% of patients in these trials were on baseline insulin, and there was no heterogeneity of cardiovascular benefit in those with or without baseline insulin. In terms of hemoglobin A1C, those were in our target. Most of these trials actually enrolled patients with hemoglobin A1C in the range of 7 to 8. There were very few patients where hemoglobin A1C at baseline was less than 7. And even in that very small cohort, the treatment effect doesn't seem to be any different. Remember, by design, all of these trials were glycemic equipoise trials, because the major objective of these trials was to rule out excess cardiovascular risk. If you allowed hemoglobin A1C to vary between the treatment groups, then you could not figure out whether the excess risk was due to differences in glycemic control or were they directly attributable to the drug in question. So by design, in the placebo-controlled group, if you had a difference in hemoglobin A1C deviating from what was required to be in that therapeutic range, you would escalate treatment with sulfonylurea or insulin. So there was a differential use of sulfonylurea and insulin during the course of the trial. And people have done analysis where even accounting for the differential use of potentially cardiotoxic agents such as sulfonylurea and insulin, you still see a treatment benefit attributable to this. In other words, the treatment benefit of these agents is not driven by increased incident use of sulfonylurea and insulin in the control arm. That has already been addressed. And we have studies with insulin showing that it is neutral with respect to cardiovascular risk. So hopefully that addresses your two questions.
Thank you.
I have one question, I think, and it's something that for everyone that treats this kind of patient agrees, these drugs are extremely underutilized. And in your experience, do you think, what should we do to bridge this gap? Because the data is there, the science is there, but if it doesn't reach the patient, it doesn't work. Or do you think it's because it involves renal diabetes and it kind of falls in the middle that's a problem?
Yeah, I think the cardiologists always punt to the endocrinologists or the nephrologists to start these medications, although there is now increasing awareness and in the academic circles, I don't see any reluctance of cardiologists to start these drugs without, obviously in partnership with their endocrinology colleagues, diabetology colleagues. It's obviously a challenge. As I said, cost is a major challenge. If you have to pay $16 for a pill per day, it is going to be a major challenge. But besides cost, there are also other issues. I mean, it's not in the favored tier of therapies from many of these pharmacy benefits programs. I think active collaboration between cardiologists and endocrinologists and nephrologists is something that we should work on. In fact, Mikhail Kosiborod has this cardiometabolic action alliance, where they collaborate, they set up clinics, they teach different hospitals how to set up these programs. Yes, you're right. I mean, for glycemic control, the use of these agents is 10 to 12%. And in heart failure, the use is somewhere between 2 to 4%. They are substantially underutilized. I mean, these drugs are like ACE inhibitors and statins. They have pleiotropic effects, and they should be utilized. So the implementation is going to be the biggest challenge with these drugs.
Thank you for answering that. There's a question from Dr. Scott Monrad. He asks, what factors drive the lower cost effectiveness of these drugs in the US compared to elsewhere? Reduced hospitalization in the US might deliver more savings?
No, they did the sensitivity analysis and they found that this was purely driven by cardiovascular death benefit. So with dapagliflozin, you do have a proven cardiovascular death benefit. With empagliflozin, and at least in the HFrEF setting, you do not have that. So it will be interesting to see whether the empagliflozin cost-effective analysis will extrapolate from the DAPA's mortality benefit or not. I think I made it very clear that I do not like analyses where one drug within the class rides on the coattails of another drug in the class, or like empagliflozin in AMPA reduced versus the dapagliflozin in DAPA heart failure. I think what we can say is that the 38% risk reduction we saw in EMPA-REG outcome was obviously an overestimate. So probably the true mortality benefit somewhere between 15 and 20%, which was observed in DAPA heart failure, and also seen with canagliflozin in Credence, and so. But yes, any other question?
I'm curious about your opinion in the heart failure population to whether one of the mechanisms, maybe the diuretic effect, or the maybe reduce use of diuretics when you are on these drugs.
In DAPA heart failure, there was no reduction in the use of diuretics in the DAPA heart failure. So this concern that you have to reduce the dose of at least loop diuretics when you're using this concomitantly was not borne out. But common sense dictates that if you have an elderly, frail, 85-year-old on 40 milligrams of furosemide and borderline blood pressure of 100 systolic, I would reduce the dose of the loop diuretic. I would reduce it by about half when I start them on these agents. But in DAPA heart failure, there was no reduction in the dose of loop diuretics. I don't know about the EMPA reduced. I haven't seen those data published yet.
Do you think, the last question, as we don't have any, do you think there will be a role in patients with worse renal function than the limits we have now? Do you think they will expand that way, or we need to preserve renal function in some way?
Oh no, the FDA has clearly said that in up to 30, you can go there. It should not be used in patients who are on dialysis or end-stage renal disease, like eGFR of 15 or 20 at this point. But you remember, Cana had a cutoff of 60 and EMPA had a cutoff of 45, and now they have reduced, for DAPA, they have reduced it to 30. And with EMPA, they've reduced it to 20 based on EMPA reduced. Will I see them going lower? I don't think so. I think what I see would be what role in pulmonary hypertension, in acute decompensated heart failure, in class 4 end-stage heart failure. I think that's where we need to see, because many of these agents that we are using in heart failure have been evaluated in class 2, class 3 heart failure, very few in class 4 heart failure. We had ARNI in Paradise MI and LIFE studies evaluated in the setting of MI and end-stage heart failure, and they were not successful. So this is an area that is ripe for further exploration with SGLT2 inhibitors at this point.
Thank you very much. That was an amazing lecture. Good to see you again and learn from you.
Thank you.
Hopefully we'll see you around soon.
Can't wait to get together.